Recording started. No,
Okay. So we will start this session. I'll welcome uh, all of uh, uh, all of faculties and our speaker and all of our friends and students. So this is a platform supported by Apollo Hospitals, Navi Mumbai, and it's a very good learning process. I think we should look forward to complete all the series. I will introduce myself. I am a Dr. Swapnil. I'm intensivist and associate consultant at Apollo Hospitals, Navi Mumbai. I have got Dr. Gunadhar Padi. He is a working HOD and intensivist consultant at Apollo Hospitals, Navi Mumbai. Along with us, we have got Dr. Uh, Akhilesh Tandekar sir. He is also intensivist and consultant at our hospital, that is Apollo Hospitals, Navi Mumbai. Uh, so I request all of students to be attentive and take advantage of this interesting presentation, which is ICU at remote locations. Specifically, we are targeting ICU in the sky. So I request Dr. Gunadhar sir to to take hand over from here.
Yeah, thank you, Swapnil. Thank you, Swapnil. And today is a very different topic. And this topic, I think, is very much interesting. And this can enlighten us what are the different recent advances in the field of critical care medicine. Now, particularly when we consider now the ICU care has gone from the land to the sky. And that is why this is a recent advances what we have chosen to enlighten the different aspect, how the critical care management at a barometric pressure which is lesser than that of the land pressure, how it is important and how to transport patients basically in such scenarios. What are the intricacies and what are the different aspects we should looking at. So with us today, very eminent speaker, Dr. Amit Dalvi. So Dr. Amit Dalvi is basically an anesthesiologist by profession, but he is also a medical director of a big institution, Human Care Worldwide Medical Facilitation Services. And he will teach us today the different aspects, physiology, the pathophysiology, and what are the care we should provide the patient while we are transferring the patient from one area to the other area by the air ambulance. So let's welcome Dr. Amit. And I again thanks all the delegates and the fellows, the colleague intensivist to present in today's session. And so without further delay, let's start. So I hand over the session to Dr. Amit. Welcome, Dr. Amit.
Good evening, everyone. Myself, Dr. Amit Dalvi. First of all, I would like to thank Dr. Gunadhar and Dr. Akhilesh for giving me this opportunity to present in this series of ICU lectures. This topic that we have, it is a very different topic which generally isn't taught that much in, or we generally do not come across this kind of transfers or this kind of education that happens. But once in a while, you do have to transfer patients, not ground ambulance, but many a times now it is now this sky ambulance and air ambulance transfers are increasing across the world. We are doing this transfers now in various countries, various states, across the continents. And let me tell you that this type of transfers, of course, you have to transfer patients who are not just fractures, who are stable, but we are also transferring patients who are very critically ill with ventilators, with inotropic supports. And we are now transferring patients with are also ECMO, who are on ECMO. We are transferring from a small place like Raipur to a tertiary care center in Chennai or in Calcutta or in Mumbai. So it's a very dynamic field. It's a very challenging field. And there are the concepts here are same as ICU, but they go beyond that, because it's like what in anesthesia we have is something kind as a non-operating room anesthesia, where you are outside anesthesia, where out of your comfort zone. So this is kind of a similar thing where you're not in an ICU, but you have to work as an ICU person with all the equipments that are available in ICU, but alone and without much help. So this is a very challenging field. So I'll just start with how this presentation will go about. First of all, I will just take one case scenario in short. Now, this aviation medicine and ICU in the sky is a very long topic. We generally have a training of around 4 to 5 days and then a secondary training of 7 days, but I'll try to shorten out and whatever is the most important points to remember, which might help you if you get a question in exam also, a short summary kind of thing, and the most important things. Sometimes if you might have to do an air ambulance transfer, so what all things you will remember, that I'll go through. So first a case scenario, then what are the modes of air ambulance travel, then a little bit about what are the most important points of aviation physiology, how the G forces affect on body, okay, in various charters, in commercial airlines, then effect of altitudes and pressurized cabin in human physiology, okay, then cases which are contraindicated or cautioned in air travel, then commercial air medical transport. So this is a very new thing that is happening. So private, it's not just a private charter plane with all medical equipments inside and we are traveling from one continent to another. Now even the commercial, a very simple airline like Air India can also transport a patient with ventilator and inotropes. So after that, and finally, we will see what are the precautions, what are things you have to keep in mind when you are traveling with a patient on a plane, and how you will make sure the transport is safe without any problems, without any mortality or morbidity. Okay. So first of all, we will start with a case. So this was one case that we did from Sharjah to Jakarta in Indonesia. So the patient was a post-COVID-19 case who was bedridden. He was recovering from stroke post-COVID, and he had post-COVID pneumonia. And the major problem was he had multiple lung cysts, a few of them which were large, and there was history of pneumothorax. And we had to travel him from Sharjah to Jakarta. Now the flight time was around 11 hours, okay, and with multiple takeoffs and landings because we had planned for a private charter. So the charter flight was could in one go could go for around 4 hours. So we had two stops for refueling. So he was a 44-year-old male, basically Indonesian, working in merchant navy, contracted COVID while he was at Dubai port, and then he was shifted to hospital, but his condition worsened, and he had pneumonia and stroke. So he had left hemiparesis basically, and he had a very bad pneumonia which was treated. But like most of the cases post COVID that we have, the thing was he got a lot of lung cyst. He had fibrosis on his right lung, which was completely right lower lobe of the lung was completely collapsed, whereas the left lung, it had a very large cyst. He was bedridden on oxygen support basically with tracheostomy mask. So they tapered him off from ventilator and brought him to a tracheal mask at 2 liters per minute. So he was maintaining a saturation of 94% on whatever that residual lung tissue was present. Respiratory rate was 16, it was non-labored, and cardiac condition was stable. So there was no issue in cardiac condition. But the lungs, they had basal creps, air entry was decreased on left upper side, and he was tracheostomized. CNS wise, he had left-sided hemiplegia, GCS E4, M3, tracheostomized, pupils were equal. All other lab reports were normal, and hemoglobin was more than 10. His chest X-ray, as I told you, had mild pleural effusion also. They had also done a CT chest, which was the size of the lung cyst was 6 by 8 centimeters in the right upper lobe. And it was written, it was communicating with the bronchus. So ABG was normal. So we planned for charter, and when we reached the hospital told us that the patient is very unstable. Since you're doing an air charter, it would be very difficult to transfer this patient considering he has that lung cyst. So we studied the lung cyst. The size was 6 to 8, and what we saw was there was communication with the bronchus, and that is when we decided, yeah, it is safe probably to go about with this case. considering it is communicating with bronchus and it's not an enclosed cyst. So the significance of this lung cyst, which is enclosed or communicating, will come later once we go through the physiology and that, and then you'll probably understand better. So this was the case. So we went about, so on day of repatriation, we kept him NBM for 3 hours. He was shifted to ambulance, brought to the airport. And in once one at the airport, he was shifted to flight. We started him on 4 liters of oxygen instead of 2 liters. Again, I'll tell you why not 2 liters, why 4 liters. We gave him analgesics, a little bit of sedations, and he was NBM. We started him on 80 ml per hour DNS. Now the journey went uneventfully and he was handed over to Jakarta and in the hospital. Now, there are various points. I'll come back to this case later, how we did it and why, what are the basic small nitty-gritties where we have changed something which is from a normal ICU. Okay. So this was the case that we did. We have done a lot of similar cases and critical cases from this, but I'll come back to this case later. So we will start with what is the cases that we do generally for air ambulance. So what kind of cases that come? So first of all, as you know, medical tourism is very flourishing, especially in places like Turkey, Bangkok, India. So many patients need to be transferred from different countries to places like India and Bangkok and Turkey. So medical tourism is very important. It is part of one of the major requirement for air ambulance transfers. Then transfers back to native country for rehabilitation. People will go to various countries for work. They get traumatized there and they have to be repatriated back to their native countries. So that is another part of air ambulance transfers. Then critical patients on ventilators and inotropic support. Some patient like it is in Nepal or in Uzbekistan or Kazakhstan. He needs a higher transport, higher medical care. So he needs to be transferred to a country which has that. Okay. And considering the terrain and all those things, and he requires it to be done very fast within 2 days or 1 day or 3 days, so that his condition doesn't deteriorate. So that is one kind of patient categories which requires air ambulance transport. Organ transplant, as you know, it has to be very fast. So fastest mode of transport currently is air ambulance. So organ transplant requires that. Patients on ECMO transfers are, like I also said, going from a small place to a tertiary care center, a metro city. So such transfers are also required, especially with COVID coming in. Like in last 2 years, there have been a lot of ECMO transfers that have been done with private charters. So the patient on ECMO can be transferred from a small hospital to a tertiary care specialty hospital. Then transfers with medical escort for various stable comorbidities like patient with a low ejection fraction, patient on oxygen, interstitial lung diseases. So they require medical escorts along with them. So that can be done in commercial airlines or private charters also it is. As well as for rehabilitation. Somebody like a patient, a worker in Dubai with a stroke. Now he cannot afford the charges for rehabilitation there, but he has to be returned to his home country. So that way is for rehabilitation, which is a prolonged care. So we have to be along with the patient on the plane to make sure he is safely transferred back to his country. So these kind of cases that we generally see for air ambulance transfers. So what are the various modes of air medical transports? So basically we divide them into 2 categories. One is the rotary wing transports, which is the helicopters. Okay, and second one is the fixed wing transfers. So rotary wing, we call it as helicopter emergency medical services or HEMS. And second is fixed wing transfers, which includes, there are 2 types basically in fixed wing. One is a short range and another one is a longer range. The longer range will include the jets and the shorter range will include the mid-range jets and what we call planes as turboprops, which have again rotary wings, but they are basically mid-sized jets. Okay, so there are 3 basic categories. So first is the helicopter emergency medical services. Now there are advancements like in medical field, there are advances in aviation. So before, as we have seen, the helicopters are basically fly for typically 2.5 to 5 hours only. So short range, short time of flight, short distances they can travel. And with time, now the tank capacities of helicopters are increasing. So this time has increased from 2.5 to 5 to 7, and range has increased to somewhere around 700 kilometers. So somewhere you can say from Mumbai to Goa or peripheries of Maharashtra. So that kind of range they have got. Okay, but they fly at low altitudes, and so basically their advantages. So advantages are they can be quickly activated, one. Okay, and within they fall within a one specific customs or airline authority aviation control. So they can be quickly activated, and they can land in different terrains, like you can imagine. But the disadvantage is if the speed is slow, because they fly at low altitudes and they have a low flying range. And since they have a low flying range, as you go up, you are affected by air turbulences, you are affected by weather conditions like temperature, low oxygen, pressure differences. So patient as well as the medical as well as the air crew is very is exposed to all these kind of turbulences. And if you're carrying a critical patient, it becomes difficult. So this kind of helicopter services are generally used in places where you require to transfer for very short distance, and especially in cases where there are crashes and you need to transfer from one place to another, and in developed countries, especially from short distances for travel from one hospital to another. So second is the fixed wing aircraft. Like we use long range jets for this. Okay, so these are powerful jets. They have generally a seating capacity of 8. One side of the jet is the seats are removed, and we put a stretcher in there. The medical equipment's there, and the other side is the place where the patient can sit. So if I can show you, if you can see on the right and the left side, what you see are the jets. So as you can see, one side is flattened out for the patient with a stretcher and equipment, and another side is the place where the medical escorts can sit. Now this place is very small. Remember this picture. Okay, it's not like an ICU with a big bed and everything and everybody can come. No, it's a very compact space where you have to adjust all your medical equipment. Similar is with helicopter. If you can see again, it is a very small space. Every machine has been tried to make in, every machine is a compact form has been purchased so that it fits in the helicopter and you get as much space, but it's still very compact space. Okay. So long range jets, what are the advantages? So advantages, they have higher speed. They fly at a very high altitude in pressurized cabins. So you can travel long distances in very short time. They have a long flying range. You can go from continent to continent, not affected by weather conditions because controlled pressurized cabin. What are the disadvantages? Disadvantages are the airstrip. You require an airstrip to land. Not every place you can get that. Okay, you need licensing and permits from airport authorities to just take off and land. So it takes time. Okay, so you cannot activate it that easily. Okay, so these are long range jets. Now there are something called a short range or turboprops who have rotary wings, but they are still jets. Okay, now these fly at an altitude which is between. So a long range jet will fly at an altitude of say around 40,000 feet, whereas a helicopter will fly at around say 6 to 10,000, around 6 to 10,000, 6,000 feet around. And these jets will fly at around 15 to 18,000 feet. Okay, so this is something in between. But so the advantages are they have a mid-range speed, a slightly longer range than helicopters, but disadvantages are again the same. They are slower than jets, again affected by turbulence, but not exposed to weather. They require airstrips, maybe shorter airstrips, but they do require airstrips. And again, they require licenses and permits from airport authorities before you can start shifting the patient from hospital. Major problem is they are very noisy. Okay, because they have a turboprops, those fans which are present, so they are very noisy. So it's very uncomfortable in these kinds of aircrafts. Now, when we used to talk about air ambulances, when I was studying in MBBS, I only knew of these fixed wings and helicopters. When I entered into this air ambulance transfers, I realized there is something called as a commercial airline transfer also. Now I did know about commercial transfer, but I only knew there is something like a wheelchair. Somebody will come and somebody, if required, you will get oxygen. But now in last few years, airlines have started giving stretchers. So at the aft portion or the back portion of the airlines, so the 6 or 9 seats at the back are flattened out and they put a stretcher there. Okay. So this is the way they put the stretcher in, and you can shift the patient on this. You have a 5-point harness in which the patient is properly secured, and you can travel also in commercial airline with other passengers. Okay, now they do have their specific medical requirements for this. They have every airlines has a medical team who will assess whether the patient is flyworthy, and only when they give a go, then only the patient can be transferred in such commercial airlines. Okay, so it's a lengthy process. So the fastest process you will get is with a helicopter and jets, and the slowest would be of a commercial airline. So a jet, maybe you can activate within 24 to 48 hours, but commercial airlines would generally take around 3 to 5 days to get approvals and to start shifting the patient. So you have to decide based on the criticality of the patient, whether how stable it is, as well as one of the greatest advantages of commercial stretchers is they are very cheaper. If you are doing a jet service, medical jet service at around 10 lakh from one place to another, you can do a similar jet service, similar service in a commercial stretcher at around say 3.5 to 4 lakhs. So your cost is going down around 40 to 60%. Okay. So commercial stretchers are very cheap, but again, they are limited by again airstrips. And second biggest limitation is these jets, the with stretchers only go with the most renowned aircrafts like Air India or Emirates, and they only go to metros. I can't take this. Generally, they won't provide a stretcher for a small place like a Mangalore or Thiruvananthapuram. So small places, they won't give this, or even like Pune or Ahmedabad. So it will only go up to Mumbai. It will go to Cochin. It will go to Bangalore. It will go to Delhi. So after that, you will have to make sure the patient is traveled by some other place. Okay, so what is the need for air medical transport? So first, medical tourism, like I said earlier. Second, a scene which is very common for people who stay in Mumbai. You can see that ambulance stuck. So it's a very common scene, and you require a air transport which is very fast and which can take the patient from one hospital to another or one place to another very easily. Third is places which are having poor medical transport, like rural places, and you now need to transfer them from that place. A patient with a stroke in some district place now needs to be transferred for a neuro intervention. Like the golden hours have increased now. Neuro intervention time has been increased to up to 24 hours to 36 hours. So you have that period where you can pick this patient from a small district place, if it has an airstrip, and bring him to Mumbai. So that kind of air transport can be facilitated and the patient's life can be saved. The same ground transport would have taken somewhere around 24 hours. So some transfers like this are very critical and they have to be done very fast. Some terrain like a Leh Ladakh, some terrain like a northeastern place, you cannot travel via ground ambulance. You require air ambulance there. Sometimes the cost factor is very high. People are working in places like Dubai. They come from small places like Philippines, Bangladesh, Pakistan, India, Bihar. Okay, so they go there, they fall ill, and the cost out there in Western countries, some places like Gulf, is very high. They need to repatriate it back to their countries for treatment at lower cost. So those kind of cases, and organ donation, like I have emphasized earlier. So this is where the air medical transport has become necessary now. Now we will start with aviation medicines. Now, since we have talked what are the various options of air medical transports, what is the need, how it is being done, what are the various advantages, disadvantages, we will come to the most important topic for us, that is aviation medicine. So we'll talk about aviation physiology here, the study of effects of high altitudes. Now, again, you have read about high altitudes in your textbook. We have had read about high altitudes in our physiology books. Now, this high altitude is very a different kind of a thing. We are not talking just of altitudes like I'm going at 10,000 feet or 20,000 feet, 30,000 feet. What are the various effects on the body? We are at a high altitude of 40,000 feet in a commercial plane, which is pressurized to an altitude of 8,000. So this is a different scenario. It is not just high altitude. You are not exposed to an environment. Okay. You are taken to a high altitude and now you are in a controlled decompressed environment. So it's a different thing. Okay. So we'll understand that as we go ahead. Okay. Then what are the effects on cardiac output? You are going at speeds of around 1.8 to 1 Mach sound of the speed. So what is that effect it is having on your intraventricular fluids, in your cardiac output, on your tissue perfusions? You have differential pressures, how it is causing effect. Then what is the impact of all this altitude at which the medical flights are flying, and the lengths of exposure also. You have flights which travel for 12 hours with patients. You have flights which fly for 6 hours, 8 hours with patients. How do this long flight, this long pressurization, this long all these factors, various factors like sounds, vibrations, turbulence, how is all this affecting the patients? How are various gas laws changing when you are in the aircraft? Okay, and their significance. What are the signs and symptoms of hypoxia? That's similar to what we have. Well, decompression in a pressurized aircraft, what happens, and what are the various stressors associated with flight? Okay, so this is something which we have learned when we were in school. Okay, so there are different layers: troposphere, stratosphere, mesosphere, thermosphere. So basically we deal with only troposphere. The flights generally, commercial flights fly at around 40,000 feet. Okay, so we will only deal with troposphere. As you go up, I'll just tell you, as you go up, the atmosphere becomes thin, oxygen decreases, the temperature cools down. So this is the basic. And the basic thing, that is nitrogen is 78% at sea level and oxygen is 20.9% at. So we remember this, basically, this is the basic. Now, in troposphere again, we have divided this troposphere from 0 altitude sea level up to 50,000 and above into 3 zones. First is the efficient zone, which is up to 10,000 feet. So 10,000 feet is something which we call as efficient zone, because at that time, a normal human person with a normal physiology, normal human body can compensate. Okay. Next is a deficient zone from 10,000 feet to 50,000 feet. This is the zone at which the jets, commercial airlines, fly. Okay. So that is the place we call as deficient zone, because at that place, if you stay longer, you will start having symptoms of hypoxia and pressure. And above 50,000, we generally do not encounter. Some jets may travel with patient above this, but they are very big and powerful jets. So above 50,000 is the space equivalent. First of all is the efficient zone. It is up to 10,000 feet. So barometric pressure falls here from 760 to 523 mmHg. Now I'll go into a little bit of physics. It will be very dry and little bit complicated, but it is very important and very interesting. So at 10,000, your pressure is coming down to 523. Okay. And humans can work at this in protective environment. Now, as you ascend, you will have some minor problems only, like a block in ears or a sinus block. And a healthy person, I again saying, a healthy person with a healthy lungs, healthy heart will compensate. Okay, now who will have problems here when even they are ascending to 10,000 feet? One who's anemic, oxygen reserve is reduced. Then people with pre-existing respiratory problems like a COPD, interstitial lung disease. Patients with cardiac disease, like patients who are having EF which has reduced, so these people will deteriorate. Okay, so this is the efficient zone. Second is the deficient zone, which 10,000 to 5,000 feet. Now look at the pressures. They have fallen down to 87 mm Hg at 5,000. So it's just 10% of sea level. And your commercial aircraft flies at 40,000 feet. So somewhere around 150 mm Hg, which is only 15% of your sea level. Now, supplementary oxygen is provided at these if you are in open in these altitudes, and human body cannot survive at around 50,000 feet. And space equivalent zone is very rarefied zone, so you cannot survive. Now you can understand these different altitudes. As you go high, the pressure starts falling, temperature starts falling, oxygen becomes rarefied. So when people required. So basically during World War II only people started having this requirement for air ambulances. And then that was the time when we realized ki, yes, we require air ambulance. So but what they found was when we are going up, there is problem is the oxygen is going down. So helicopters also were not able to take patients longer. So they started thinking about jets, and in jets, now how to counter this low oxygen and low pressure. So they started pressurizing. Okay, so pressurizing the jets to 8,000 to 8,500 feet. So this, the planes which are flying, commercial planes as well as jets, they fly at 40,000 feet, but they will give you an atmosphere which is not at sea level, but at atmosphere which is equivalent to 8,000 to 8,500 feet. Now, since this is going up, your oxygen is reduced because the oxygen is now more spread out because of the low pressure. So your oxygen availability will reduce by 25%. So at sea level, if you have 21% in an aircraft, in a normal commercial aircraft, you will have only 15 to 16% oxygen because it is at 8,000 feet pressurized cabin. Okay, and a normal saturation which you have around 98. If you see, if next time if you go and carry a pulse oximeter with you, your saturation will, and you will see your saturation coming down to 90 to 92. Okay, so this is how they countered the problem of pressure. Now, since we are going to this, so basically this is the difference between the right side, unpressurized, what helicopters have, and the left side is the pressurized, which the jets have. So the jets are expensive to build and they have complex maintenance. Helicopters, lower cost of manufacture, but short, and they have maintenance is less. Operational capability, they have higher altitudes, fly above weather. Jets, so turbulence is less, whereas the helicopters have smaller range. So this all we already have discussed. Okay, I'll go to the next point since we have short time. How gas laws affect. So you know the Boyle's equation. So its pressure is inversely proportional to volume. So as we go up, the volume decreases. So what is important? So as you go up, this air which is there, so consider a enclosed balloon. So when you go up in the aircraft, if you carry a balloon, that balloon will expand. Okay, and as when you are going down, this again will contract. Now I'll tell you what happens. A balloon inside has a specific X amount of pressure. Now, as you go up, the atmosphere outside the balloon, the pressure starts dropping. So the balloon has a space to expand. Okay, so that is why the balloon will start expanding. And how much it will expand? Okay, so this becomes important when a patient has an enclosed lung cyst. Okay, so if there is a cyst which is having a capacity of say 400 ml, okay, in the lung, so it is present in the lung, and it is, of course, it has destroyed some lung tissue and it is affecting. Now as I start going up, okay, so the cyst is now starting expanding, compressing the remaining tissue. Okay, and when will, how much will it increase? So at around 18,000 feet, where the pressure would be 360 mm Hg. Okay, so at 18,000 feet, it will be 800. So it will be doubling at 1800 feet. Okay, so at that time, patient's lung would be so much compressed so that his saturation he will start having dyspnea. Now, how it affects in the plane? In the plane, you have around, you are flying at 8,000 feet. So the factor that we generally calculate is around 1.4. So if you have a lung cyst of 400, so it will increase to around 560 ml. So around 1/3 size it will increase. Okay, so that is how you calculate. So a small cyst won't be a problem, but a cyst, enclosed cyst, which is big, which will grow in size, and it will expand, compress the lungs, and reduce the respiratory capacity. Okay, so like you see at 8,000. So second law is the Dalton's law. So you know the partial pressures law. So as you go up, okay, your vapor pressure remains the same, but your oxygen percentage is reducing. So somewhere at sea level where you had an inspired oxygen, which we all know, the atmospheric is 159 mmHg as per 21%. If you minus the water vapor pressure, it comes to 101. At 8,000 feet, which is in the plane, it comes to only 60. Okay, so you have reduced availability, and that is why your saturation is dropping. But as a healthy person, you can you can easily go about with a saturation of 90 to 95. So generally you won't feel that pressure, but person who is already on a border like 90 to 95% will start having symptoms on plane. Okay, again, atmospheric pressure decreases, so oxygen pressure decreases. If percentage of oxygen does not decrease, so basically it is just spreading out of oxygen. That is why you are having the problems. So that is the Dalton's law and how it is affecting your oxygen supply on the aircraft. Again, there is something called as Graham's law. So Graham's law says that the greater the difference in the partial pressures, the faster will be the diffusion. So as you go up, again, you can see at sea level, this difference is 60 mmHg between alveolar and venous PO2. But if you see at 10,000 feet or something like an 8,000 feet in plane, this partial pressure difference has come down to 26. So even your diffusion of oxygen is affected. Okay, so that is how it is affecting. Now, symptoms of hypoxia, I think everybody knows. As the oxygen starts reducing, patient becomes restless, headache, there is confusion, then there is rapid heart rate, rapid breathing, anxiety, and so we will concentrate on, so this all will be seen in the patient in which you are not giving oxygen and who was already on borderline, who was having a saturation of 90%, PO2 of 60 mmHg or 70 mmHg, and now he is in plane. Okay, so he will start experiencing all these things. And if I say of a medical person who is traveling, medical escort, what will he have? His saturations will go down to 88 to 90%. And if his night vision will reduce by around 25%. So his work efficiency will start falling. Okay. So as you get hypoxia, person will start hyperventilating. Now hyperventilating will again compound the problems. If your patient starts hyperventilating because of anxiety, because of hypoxia, he will again start having different symptoms like dizziness, nausea, cool skin, pallor, twitching. So you are now compounding the problems. The problems have now, it started, the spiral has started. So patient is now started to going bad. Apart from that, what are effects of alcohol? Alcohol will hamper the ability to take up oxygen. If you are at 8,000, you will feel the effects of 10,000 feet. There will be clouding of judgment. So all these effects will start happening. Apart from that, you have different stressors like gravitational forces, G forces, humidity. It is very less. It's a dry environment. Your water levels go down, oxygen levels go down. There are shakes, there are vibrations, there is turbulence. In helicopters, you are exposed to low temperatures. Then there is atmosphere, there is problem of noise, there is spatial disorientation. So you can understand a patient who is in borderline will have so many problems. Okay, so carrying even a normal patient who looks normal in the hospital in the ICU will become bad in a plane if you are not looking into, if you do not have idea of all these things. Okay, now what are the effects of G forces? So basically G forces, two compartments will be affected. One is the intravascular space, the heart, and the cranial component. Okay, so there are two basic times where these forces act. One is at takeoff, one is at landing, and again at during turbulence. So the at takeoff and landing, it would be in a horizontal plane, whereas at turbulence, it would be in a vertical plane. Okay. So when you are going, I'll just show you. Okay. So this, if you're going and you have the head end at the pilot end. Okay. And you are placing the stretcher and placing the patient in such a way that the leg is at the tail end of the plane and head is at the head end of the, or to the pilot. During the plane has to accelerate, it accelerates very fast and G forces act on you. So all your blood will flow into the legs during the initial when it is taking, and it's not a small time. The time is around 3 to 4 minutes. Okay, to reach the altitude, the set altitude of 40,000, it takes around 5 minutes. Okay, so all this while your blood is going down. Similarly, if your leg is at the pilot end and head is at the tail end, like in the picture which is lower, your all the blood and all pressures will make sure your fluids are going to your head. So this will be a problem in a patient which is having increased intracranial pressure. So his all fluids are rushing towards his head, so he will worsen. Okay. So that is how your G forces are acting. So to reduce this G forces, what do we do? So basically we generally ask the pilots to have a very smooth takeoff and descent. We generally, it is advised to make sure the landing and takeoff takes in a long strip so that the pressures are less. And again, the type of aircraft, if it's a large aircraft, you require large amount of G-force to take it forward. So the more force is acting. So smaller aircrafts will have small effects of these G-forces. Now, again, it depends on the kind of patients. So if we have serious patient who is on inotropic support, okay, we generally keep the head end towards the tail, so that when the patient is taking off, okay, the blood supply will generally rush towards the heart and it will not affect. As well as like in ICU, when we transfer, we generally increase the inotropic support a little. So that we also do. Blood this we generally do. If the patient is having ICP, raised ICP, traveling with the EVD, we generally make sure his head end is towards the pilot so that the fluids are going down and the pressure is not increasing. So these are the various scenarios. We have to tailor it. That way we happens. Okay, then the humidity also. So humidity also falls. Okay, and it's a very dry environment, as you have noticed in the aircrafts. So the air is changed every 2 minutes and as little moisture as possible is used. Okay, so again, your water level starts decreasing, and like in ICU, we know we have to maintain good hydration levels. So again, it is a challenge. So we have to give more fluids to the patient as well as the medical escort himself. If he should be healthy, so he should be drinking more of water and less of caffeinated drinks or carbonated drinks. Effects on ears that we know of: barotitis media, barosinusitis. Even teeth, there is barodontalgia, so cavities, recent fillings, those will expand air and it will cause a lot of pain. GI tract, especially if you have intestinal obstruction, something like a megacolon or something, even an obstruction which is huge enough, it will expand further. It will cause pain, it will cause nausea, vomiting. If it is too large, it will compress the vessels, it will cause syncope, it might even rupture. Many a times partial obstructions are converted to complete obstructions. Musculoskeletal, there is, since the pressure has dropped, you can understand the tissue swells. There is increase in edema. Okay, so muscular systems are also affected. Respiratory system, like I told you, the encloses, they expand. Eyes, some people have the therapeutic air bubbles. They, or something like in a patient with helicopter, traumatic eye injury, these gas bubbles can expand and compress on retina. Retina is very sensitive to oxygen. So your retina will start having ischemic effects. CNS, intraventricular pressures, like I told you, and the CVS. So now we have seen what all effects these have on different body conditions. Okay. Now, so accordingly, we generally have oxygen on board. If we are traveling with a patient, we generally carry tanks of oxygen so that this oxygen deficiency is countered. So we have different kinds of tanks. If you have air, if you are in a commercial aircraft, they will generally give you a type D kind of a this type D kind of a air oxygen tank, whereas in private charters we generally have a type E. So your type D has a capacity, various capacities, as much oxygen you're using. So accordingly, you will have different times. So an airline cylinder, which we have, it will give you oxygen at up to 4 liters only, and it will last for around 1 hour. Okay. If you are using it at 4 liters, if you are using it at 2 liters, it will last for around 2 hours. And your bigger cylinders will be lasting more. So you generally have to calculate, like in this case from Sharjah to Jakarta, we carried 4 E cylinders. Even though he required 2 liters, we were traveling for a longer time. So accordingly, so also we have to also calculate the buffer. It's not just the air time, it's time in travel, getting into the aircraft, getting out of the aircraft, getting into the ambulance from at various airports. So you have to take into account all these things. Apart from that, your flow meters also function at a different way. They are calibrated at sea level. If your flow meter is giving 2 liters at ground level, if you take it at a higher altitude like an airplane, you can see that it is giving a oxygen, instead of 2, it is giving 2.6 liters now because of the low pressures. Now this is a study which was done right back in 1993. Okay, so this is how it differs. Okay, now there are various equipments which function very differently, like flow meters I told you, splints and casts. Okay, now air splints, there are something called as air splints that generally is used, in which pressure is applied so that the fractured part or the part which is repaired is kept in a proper position. Now, if you, like you can imagine, if there is increase these differential pressures, these splints will have different pressures also. Your tissues might be compressed too much because they are expanding, plus you have tissue edema. So you can understand the splints will compress the tissue. You might get a compartment syndrome, you might get cyanosis. So you have to frequently check if your pressures are okay, if your limbs, which is plastered, which has splints, which has casts, whether it is getting good circulation or not. Then there are pressure infusers, which we carry in chartered airplanes with patients having hemodynamic problems, ECMOs. So there you have to make sure these are working at right pressures. You have to alter the pressures. Something with a ventilator, if you have an ET tube, it has a cuff. So generally what we do is, since there are pressure differences, the cuff will expand, it will come down, it will deflate. So we pull out the air and we push in the water so that there are no much pressure related changes. Invasive pressure monitors, IABPs are also used. People are transferred with IABP also. So you need to change their pressures. IV solutions. So IV solutions, the compression becomes different. So the rates will change at which the liquids are being given. So that is a problem. So all these equipments are affected by even an altitude, a pressurized cabin at 8,000 feet, which is in a normal commercial airplane or even in a jet. So don't expect you are in an ICU environment and you are having the equipments which are working like you were having in your hospital ICU. This is a different setting and you have to check each equipment. You have to understand the physics and you have to change their settings. So what can you do in such cases? So you can give supplemental oxygen. Like we said, that 2 liters for that patient, he was maintaining 94%. We already knew he is on borderline. His lung tissue is already depressed. Lung tissue is already gone. Plus he has a lung cyst which is going to lung cyst which might expand. In this case, I'll tell you later. So we know that he is on borderline. So we and it is going to worsen. So we already had this idea because we knew this physiology. So we started him on 4 liters, plus we took another buffer cylinder. So we in all had 4 cylinders, large E-tank cylinders. Okay, so you have to increase the FiO2. So you can either use nasal cannula, simple mask, non-debridable mask. So one limitation I'll tell you, in commercial aircrafts, they will only give you oxygen up to 4 liters. They cannot give you beyond 4 liters. Whereas in a charter plane, you can bring it up to 15 liters like normal. But if you're carrying a patient who's borderline at around 92%, and you expect you can get somewhere around 15 liters, no. Airline can give you only up to 4 liters oxygen, a commercial plane. Then you have second thing, first is you are giving the oxygen to the patient to keep his saturation up. Second, it's a dry environment. Everybody knows water has hypotension, water, this creates a lot of problems. So make sure your patient is hydrated, especially if you are if he's on ventilator. Already it's a dry air. So make sure you're giving good amount of fluids to the patient. Portable ventilators, you cannot use the moisturized air. Okay, so you have to give dry air, but you can increase the IV fluids. If he is on nasal prongs or mask, give him humidified oxygen. You use lubricating jellies for mucous membranes. Before traveling, identify the patients who are at risk, like anemic. Generally, we have a threshold, airlines have a threshold of 10 gram percent. Okay, so below that, they will not allow the patient to travel. Okay, patients with interstitial lung disease, with low ejection fractions. So you have to identify them. You have to optimize them. If HB is 8, give him blood transfusions, get it up to 11, 12, 13. Okay, if he is having ejection fraction, he's just had CPR, wait for some time for that ejection fraction to come up. Okay, get him on medications, get his cardiac output up. Okay, get him on spirometry, increase his lung capacity, optimize the patient if possible, if he's not critical, and then only you can transfer. Coordinate with the pilots. We have to coordinate with the pilot. If it's a private charter, you have a chance of doing it. In commercial planes, you cannot. In private charter, you have to tell pilot to take off has to be slow, the landing has to be smooth. Okay, then you have, if required, if your patient is desaturating, you will have to ask the pilot to reduce the altitude so that the pressure differences are reduced and the patients do get better as soon as they come down to an altitudes of 1000 or 2000. Then even coordinate with air hostess for oxygen cylinders. So that why? Because when oxygen cylinder is reduced, now see, the airline staff or the pilot is not a non-medical person. He doesn't understand the importance of an emergency, and you are alone there. Okay, so that is where you have to be very proactive. Your cylinder is half over, you have to tell them, get me the next cylinder. Okay, if you are expecting any problem, get those 2 people around there to help you. So you have to be very proactive. Then in gastric obstruction cases, make sure you give the patient antiemetics and analgesics prior, because he is going to experience pain because of expansion of gases. He's going to experience emesis. If you have an NGT, decompress, remove the fluids in the stomach so that the aspiration chances are reduced. If he has colostomy bags, make sure venting is done. Support the airway if vomiting occurs. You should always carry a suction equipment, and many times patient aspirate, and that is why we generally ask them to make sure that they are having at least 4 to 6 hours of NBM prior to traveling. And whenever they are traveling, we generally use an IV fluid, or if required, only water for them. And we do regular glucose monitoring. Give them propped up position with the hand end to the pilot end. Lower the altitude of flying if possible. In respiratory system, rule out pneumothorax. Okay, it is going to expand, it is going to reduce the respiratory capacity. Generally, what they say is if there is a pneumothorax, you have to wait until the ICD is removed. Now, there has been a few research papers, different aviation authorities, British, American, they have different standards. Some people say 2 days are good enough. after removal of ICD for travel. Some people say 2 weeks are enough. So we have to go as per the country that we are flying from. Needle decompression, in case you have to be ready with the specialized equipment for needle decompression. You should be thorough with your needle decompression technique because it can happen. Okay, we have patients with COPDs, with patients with bulbous lesions of the lung, which do burst and they can go into pneumothorax. Restrict cabin altitude if you are in charter, assist ventilation when needed, give oxygen, give NIV if required, give supplemental oxygen. Musculoskeletal system, keep checking the tissue for warmth, color, sensation, cyanosis. Provide analgesia. The tissue is going to swell. It is going to cause pain. Keep checking for compartment syndrome and keep the fractures in elevated possible because there is going to be edema. Cardiovascular system, avoid hypotension. Keep patient hydrated. Keep checking the blood pressures, especially during takeoff and landing. Support blood pressure during takeoff. If you are having a patient on inotropes, especially during takeoff, landing, just increase the level of inotropes so that the patient is compensated for that G forces. Adequately strap the patient. Do proper padding, especially if he has splints. Keep the equipment. Even the equipment has to be strapped. There are cases where the monitor itself during turbulence has hit the patient. Okay, so we do not want additional injuries. The place, generally charters have their spaces where they lock the equipment. But if you are traveling in a commercial, you have to make sure they are put in the belt and they are strapped. Adequate hydration, dry. So jellies for mucous membranes, give analgesia. Sedation has to, it's a double-edged sword. You have to be good with your sedation skills. You should be able to understand because too much sedation again can create problem for you. Fever, always make sure you treat fever, or at least give a preventive paracetamol. If you are on long journeys, it will prevent fever. Fever will again increase the oxygen requirement. So make sure fever is reduced. Fever should be absent at that time. Okay. And analgesic, paracetamol will work as analgesic also, plus it will prevent the fever also. Avoid hypothermia, especially in pediatric and infants. Now, these are the most important points, which are not just for the ICU, but this is what our experience is. So these precautions are the most important. You might be a very good intensivist in your hospital, but if you do not follow these points in this slide, it is going to be a difficult task for you. It might be a big problem. So, okay. So first of all, do not. Now the airline staff and the pilots will ask you to hurry everything because they have their own specific times. No, you are the medical person. You understand the complication. You should do everything at your pace, at what you are comfortable. Okay. Plan everything in advance. You should know the patient history completely. And if he is the patient with COPD, make sure you have adequate oxygen. You have your oxygen cylinders. They are ready for giving oxygen. We keep our intubation sets or LMAs ready in case we require to intubate. Communication is the key. You have to communicate very well with the patient. Patient is in a very anxious state when these kind of transfers happen. Keep consoling the patient, keep talking to the patients. You will catch their problems very early. Okay. Have emergency medication loaded. We generally carry a loaded syringe of epinephrine, a loaded syringe of atropine, a loaded syringe of 1:10 adrenaline with us. We do not have, it's a very fraction of time in which the complication happens. You have a very cramped space. You won't get time. By that time, patient would go into arrest. Okay. So make sure your emergency medications are loaded and ready. Okay. Use cautiously the sedation. Analgesia has to be given. Analgesia is very important. Okay. Patient is anxious. It will increase the cardiac output, heart rate. It will increase oxygen consumption. Give a very good analgesia. If possible, give nice sedation. Okay. Keep them NBN. Chances of aspiration are very high always. Do not leave the patient unattended at any time. This is the biggest mistake. Even if the patient is seems okay when you are shifting him from ICU, he might be borderline. And like I said, borderline patients crash in aircraft. Make sure you are attending him very well. Okay, continuous monitoring, have adequate manpower, especially while shifting. It's a very difficult task to shift that patient from a small aircraft door. Okay, so make sure you have adequate manpower. Keep vigilance at, especially at takeoff, at landing. Every time there is a turbulence, keep checking. And entry and exit from aircraft. And during entry and exit of aircraft, make sure your all ventilators are connected. Okay, make sure your syringe pump. I generally do is, what I do is, if it is a very small period, I generally disconnect the syringe pump, or block the syringe pump for a while, just for a minute or so. Okay, so that in the bolus or doesn't, but every ICU person has his own choices. So the entry and exit has to be very meticulously planned. Okay. Now, which are the patients which require medical expertise? Patients with congestive heart failures, with low EF, STEMI patients within the last 2 months, non-STEMI patients, low ejection fraction, cyanosis with right ventricular failure, respiratory acidosis. Now, all these patients, if stabilized, can be transferred in charters. Okay, with medical escorts, but with a person who has the right medical knowledge of traveling in a plane. Okay, and how to manage a patient in a sky ICU environment. Okay, patients with sickle cell disease. Okay, you know that the reduced oxygen will cause sickling and it will precipitate a crisis. So these patients need medical expertise while traveling along with supplemental oxygen, and they will need an altitude limitation at 2000. Okay. Now, again, some people call this as contraindication, some people carry with them, and some people call it, people say these kind of patients need to be cautioned for air medical transfer. So patients with large or acute intestinal obstruction, rule out such patients, okay, or optimize such patients. Megacolon cannot be done. Recent GI surgery, there is a gas in the colon which has not been passed. Okay, if you travel, make sure this if this patient is traveling via aircraft, the air can expand and the sutures can get disrupted. Okay, it will come out with perforation or disrupted sutures. Large pneumoperitoneum, it will expand. Large pneumopericardium, pneumocephalus, it is going to make sure the patient gets deteriorated. Gas bubble in the eye. So you have to be very cautious. Now, there hasn't been much research how much volume of air, how much volume of pressure that these organs can handle. Now, different people say different things. Different societies, different authorities have different numbers for this. Okay, so we have to just assess as a clinician what all these, what according to you, whether he is able to, will he be able to tolerate the pressures and oxygen level that is present. Okay, so this is in short about the air medical evacuation, a little bit of aviation physiology, and what precautions. It is a very different ball game from ICU. It is ICU only, but it's a very advanced ICU, and you are alone, and it is very challenging. Okay, so in short, I have tried to tell you what is there. This is all the presentation I had. Okay, thank you very much for giving me time, listening patiently.
Thank you. Thank you, Dr. Amit. I think it's a very good presentation and a very good elaboration from your side. It has cleared almost most of the doubts what is there in the mind of an aviation intensivist, I can say. Just a small extension to the talk. Like, can you just highlight what are the different areas you need to look after when the patient with an ECMO being transported? And second question is like, what are the medical legal issues involved in such kind of transport?
Okay. So first of all, I'll go with ECMO. So ECMO, what happens is basically when the patient has interstitial lung disease, I think there's a little bit. There is a little bit of.
I just request everybody to keep the mic on the mute mode.
आणि 3 वर्षामध्ये किती वेळा लागतात प्रत्येक गोष्टी 3 वेळेस लागतात. फर्स्ट इयर सेकंड इयर ठरलेलं आहे.
Ayub, can you make Wait for the delegate in silent mode.
मग तुम्ही काय मागितलेलं
सर्जरी होती
गायनेकोटी पण करायला पाहिजे
मी गाणे काय गेली सर्वात जास्त लेबर ओटी गेली आमच्याकडे काय करता इमर्जन्सी मध्ये जो
Okay. Okay.
that's one.
So I'll go start with ECMO. So what happens in ECMO is basically, doctor, the patient is already having a lung which is bad. So what we do is whenever we get a patient request for air ambulance transfer with ECMO, the ECMO technician will first go to that patient. Okay, so he has to first attach the ECMO to the patient. He has to stabilize him. We cannot attach the ECMO at 2 o'clock and start aircraft at 4 o'clock. Okay, so 24 hours prior, the ECMO technician will go there and he will attach the ECMO to the patient. He will stabilize the patient, bring his saturation up. Now, once that has happened, after 24 hours, the charter is active. Okay, so it will take a day for patient to be stabilized. With the ECMO technician, with the intensivist, and with the paramedic, we will start moving the patient from ambulance into the aircraft. Okay, now ECMO will not have that much of pressure changes. Now, only problem that can happen is disconnections. Okay, and you can titrate the oxygen levels with ECMO. So basically, the only problem that comes is once you have ECMO, you cannot initiate it within at least up to 24 hours. 24 to 48 hours are required to stabilize the patient on ECMO, and then only you can transfer. Okay, so this is how ECMO transfers happen. There is not much of a problem with, and generally it will happen with charters only. Commercial airlines will not allow you ECMO. So they can fly at low altitudes if required, but generally with oxygen cylinders and ECMO machine, you can titrate the oxygen level, so there is not an issue. Okay, the second you were asking, what was your second question?
It is regarding the medical
legal, yes. So generally medical legal aspects are very important. We generally have a high risk consent form like we have in ICUs. Okay, now if you're traveling from, suppose from US to, you are traveling to India, okay, and the patient is desaturating and unfortunately your patient dies. So what is generally done is the pilot informs the nearest airport authority, okay, and he will land the aircraft there, and their patient will be declared dead. All his certificates will be issued, and from there the patient's body is transferred to whichever his native place or whichever is the destination. Similar is for commercial airlines. Now, if you consider the responsibility or the medical legal responsibility, different places have different countries have different rules. We had, during our training in aviation academy in Canada, we had asked the same questions. So what the thing is, even if you have your high risk consent form, in which the patient's relatives or the presenting party has absolved you of any responsibility or liability, but the country with which that death happened is the medical authority who will look into the matters. Similar, they will have a committee and see whether all the things that were, which were to be done, like which were reasonable medical care was given or not. So that medical authority will look into it. Okay, and if you land in Britain, your laws of that land will be followed. That will happen. Okay, now there is no cover, there is no specific high risk consent or anything which is universal. Everybody has to create its own. You just have to, what was told to us was that you just have to make sure what you are doing is as per the standard operating procedure that will be followed in any country. You have to give a reasonable medical care to the patient. If that is good enough, you have no problem. That is the thing.
Thank you. So we have with us two other good big organizations, like one is the Excel Critical Care,
yes,
and the critical care unified. So both of them have actually the critical care unified specifically has such kind of patient transport systems.
Yes.
So if any questions from any of this group, they can put, and Dr. Amit will be happy to answer those questions.
Yes, please.
And we have one or two questions from the chat box, like already you have explained, like hypoxic patient is a challenge.
Mm.
So it is basically we have to be careful when the patient is hypoxic before the transport.
Yes,
And,
I would, doctor, I would say not just hypoxic, a borderline patient. Like if I go to see a patient who is transferred for via commercial or charter, okay, and he is on a saturation of say 92 to 94, even that is a red flag for me because he is border, and in the aircraft he is going to desaturate. So I have to accordingly adjust. I have to consider him as a hypoxic patient only while traveling, and I have to accordingly make sure oxygen is supplied to him, and I have to be ready with all the things, NIVs, ventilators, so that he might require it. So not just a normal looking patient with a low saturation is also a problem for air ambulance transfers.
right. And suppose the patient is intubated,
Yes.
so this question is from Dr. Nishant, like what about the oxygen consumption and cylinder optimization?
So the cylinder optimization is not a problem. Cylinder is again a pressurized component. Okay. Only the problem will come is where your cylinder flow meter. Okay. So the flow meter will deliver more amount of oxygen and your oxygen cylinder will deplete fast. So if your airline has told you that at 4 liters, it will last for 1 hour, your cylinder will finish in 45 minutes because of the pressure changes. So you have to be ready for that with an extra cylinder. Okay. The ventilator per se will not have any problem. It is just the oxygen cylinders that you will have to be careful of. That is the thing.
Okay. And any challenges during intubation? Like you means while during intubation, any precaution you means you take?
Actually, precaution is not there. It's the same as the others. Okay. The only problem is the space. Okay. And we generally do carry our advanced airway. We carry McGill's, we carry Bougie, we carry LMA. The only problem is the space. Okay. That otherwise intubation is the same as you do in an ICU, but you do not get a proper position. That becomes the problem. Because
can I ask a question? Hello.
Yes, yes, please.
Hi, Acha, in your discussion, you have told that anybody with a pneumothorax, you prefer to remove the ICD and then wait
Yes.
for certain days and then
Yes.
you want to travel.
Yes.
So what is the logic behind that? Suppose somebody has come with a simple pneumothorax and then you want to transport that patient.
Mhm.
So in the aircraft, his ear will expand.
Yes.
So is that a kind of good idea to keep the ICD inside and then travel?
See, if you go through the research papers, we had this patient of pneumothorax, the same paper. So we went through various research papers on this. Most of the most of these authorities say if you have a patient which is not critical, okay, and you have time in hand, and you can make sure his pneumothorax is completely gone. Okay, so minimal pneumothorax is okay for them. Okay, something like a mild 10 to 15 ml is fine with them. Okay, so what they recommend is that you should make sure that pneumothorax is not big. You have a chest x-ray which is done prior to your transfer. Okay, and the pneumothorax is as far as possible completely resolved. With regard, and for them, removal of ICD, complete resolution of pneumothorax is the prerequisite because they want to make sure complete safety. They don't want to give any leeway in their guidelines. Now, the second scenario comes where you are saying there is an ICD. Now, there is a traumatic case which needs to be transferred from a small place in Leh Ladakh to Chennai via charter. Okay, so there what happens is there you have to travel with an ICD. Okay, so that is the place. Yes, you have to travel, but you have to make sure the pneumothorax is reduced. So you are putting an ICD. Okay, now the challenge comes whether the pressure changes will cause its expansion. So your ICD will take care of it. Now the problem only is keeping those levels, those fluid bottles at a lower level. Okay, whenever you are transferring from ambulance, from the hospital bed to the ambulance, ambulance to the aircraft, aircraft wapas to ambulance, or whenever there is turbulence. Okay, so the fluid shouldn't go back. If you clamp the ICD, then it will again cause expansion. Okay, so yes, you can travel with an ICD. It's not a complete no, but you have to be very meticulous while transferring. You have to be very vigilant. You have to keep seeing the saturations, the chest rise, and you have to keep seeing the flow column, and you have to make sure those ICD bottles or ICD equipment is at proper level. Yes, you can do it, but it's only in patients who require it. Otherwise, if you have time in hand, let the normal physiology come in, let the pneumothorax reduce, and then you can transfer him for the safety of the patient.
Okay, okay, thank you.
And one question is from Dr. Jayanti Lal. Like, what is the cost of the transport from US or UK to India, either ECMO or on ventilator? Because this cost is a big issue.
Cost is, of course, a big issue. Yes. So from US to
US or UK to India, either the patient is on ventilator or if the patient is on ECMO, what are the cost in these two kind of scenarios?
cost, actually,
Dr. Amit, can I answer on this?
Yes, sir. So you would be better person
Okay.
to answer this.
Hi, Dr. Gunadhar. How are you?
Yeah, fine, Dr. Hidayat. How are the things?
Okay, all good. See, there are different modes of repatriation in a domestic and international. In domestic, we have a many fleet available from turboprop to Learjet. And in internationally, we have a big size jet. It's a charter private plane. And another option, we have a commercial airlines transfer. In commercial airlines, UK to Mumbai, or in India at any place like Mumbai and Delhi, will cost around 18,000 USD to 20,000 USD for a normal patient who is not on ventilator. Patient who is on ventilator will cost around 28 to 36,000 US dollar. It's roughly around 25 to 30 lakhs rupees. If the patient is in US and Canada, that will cost around 40 to 45,000 US dollar in commercial. If we go for a charter, again there are two types. One is a small size jet. The speed is same, but the refueling halt will be more. The Learjet will take almost around 6 refueling halt from US or Canada to India. And a big size jet like a Challenger or a Gulfstream will take around 3 halt from US, Canada to India, and from London to UK to India. Learjet will take around 2 to 3 halts, and the big size jet will take only 1 refueling halt. And the cost for Learjet from US, Canada to India will be approximately 180,000 to 250,000 US dollar. And from UK, it costs around 150 to 220,000 US dollar in a private charter. So in commercial and charter, there is a huge difference. If patient is on a ECMO, the ECMO will cost another 10 to 15 because of that. Sir, again, there are few VIPs we shifted from UAE or from Canada and from US in a private charter. So they had hired, in fact, business Boeing jet. So business Boeing jet is same like commercial airlines, which goes from India to Canada with 1 refueling a halt, technical halt in between, or no technical halt. But that cost more than 450 to 650,000 US dollar. So these are the different modes of repatriation. Cost is not a problem. Patients who are there are many. There is a recently one born patient of 7-year-old post Deepavali shifted from US, from India, Delhi to there, and the one company has sponsored the entire cost of the repatriation. That was around 280,000 US dollars, absolutely free of cost. That is, there are few organizations who also need, and people who cannot afford and they are stuck in US, UK, Europe, or Middle East, we can do comfortable combines as a stretcher case, and it will reduce cost, as Dr. Amit Dalvi has around 60 to 70%. And there are different airlines. Emirates will cost more, Turkish will cost little less, Air India costs little less. Around 7 to 8 days, and Emirates takes around 48 hours for clearing it. It's not like that. Dr. Amit has mentioned only 40% FiO2, 4-liter oxygen we will get. But over a period of time, as we are doing this since almost more than 2 decades, so we have the patient is stable and oxygen requirement is only high. Otherwise, there is no issue. We have a Y connector and we have Eclipse POC.
POCs.
So we can get a 3 liters. So there will be approximately 50 to 60% FiO2 we can give for a long journey also. And nowadays in domestic air medical evacuation, cost is very reasonable. Previously, we used to do from Raipur to Mumbai or Ahmedabad, Raipur to Mumbai, almost around 8-9 lakhs rupees. Now we are doing it in 6.5. Ahmedabad, we are doing it in 5. Delhi to Mumbai, we are doing it around 6.5 to 7. The cost has significantly reduced because of competitive market now. And there are more aircraft available in India. Previously, there were only 1 or 2, but now we have around 15 to 18 aircraft for air medical evacuation.
Okay.
Sorry.
Any insurance cover the patient can opt before for such kind of transport?
There is a very important revolution is going on in Europe or in the developed countries. It's completely insured. So they don't have to pay anything if they have a medical health insurance. However, if you have a travel insurance, air ambulance is covered. Okay. In India, the health insurance companies are little dicey basically, because they have a premium up to 5 lakh or 10 lakhs. There are very few people who are having some insured is more than 20 lakhs or 30 lakhs. But there are few people who are having global corporate solution, and they are taking the policy for their entire employees. For them, the sum insured is up to 1 crore. So such insurance companies are giving cashless facility to for air medical evacuation also. And now there are many insurance companies coming up with this product also. They are going to provide ground ambulance cashless. They are going to provide home care cashless. They are going to provide air medical evacuation, domestic as well as charter cashless.
Okay.
So that talk is already going on. We are one of the committee member in few insurance company for the final underwriting and policy making.
Okay, great. So that will be wonderful. I think that will be one of the revolution which everybody like to see in the field of aviation medicine, particularly.
Correct. Absolutely right. And I just wanted to highlight one thing. Nowadays, we all know the golden period of neuro intervention has increased. Previously, it was 6 hours. Now it is around 18 hours. So recently, we shifted one patient from Akola. Patient was a family friend of a doctor who is a neurosurgeon there at Akola. He called me doctor, there is a case we have to do neurointervention at Pune. There was an MCA territory infarct. We activated the flight in 2 hours. We reached there after admission of patient on the 4th hour, and within around 8 hours, we shifted the patient at Pune,
Ruby Hospital.
Ruby, and immediately cardio intervention done. And patient went back home by a car by road from Pune to Akola, I think around after 8 days of hospitalization. So in such scenarios, we can contribute a lot to the nation and prevent permanent disability, basically.
Oh, that's wonderful. That's wonderful. I think
And same thing is about ICMO. There was one patient of Indian Oil at Jaipur. We got a call during pandemic. Patient was an employee of BPCL, Bharat Petrochemical Limited. One of my ICMO specialists and MD anesthetists with critical care. I sent them via commercial airlines. They initiated a ICMO. Patient was not even maintaining on prone F5. PO2 was around 48, 46. And they reached around 11 p.m. in the night and started initiation of ICMO at around 12. And we observed the patient till 10 a.m. in the morning. Then I called a jet and immediately shifted to Chennai. And that patient also successfully recovered at Chennai MGM. So that's what we are doing in India. We do have offices in many countries in the world. So here we are more focusing now in academic point of view. So how we can associate with the existing critical care organization and contribute for a good healthcare advancement to.
I think your network is not reachable.
It's okay. I am basically out of Bombay. It's a year end. However, now can you hear me?
Yeah.
Okay. Yes, Dr. Amit, is up to you.
Yes, I believe if anybody has any questions.
Hello, Dr. Amit.
Yes. Yes.
Dr. Amit.
Yes.
Dr. Zia here. I would like to add what Dr. Khan said.
Yes.
Hello.
Yes. Yes. Please go ahead, sir. You are audible.
There's quite a disturbance there, actually. Hello. Yes. This is Dr. Zia. I'm a director for GCC for Human Care Worldwide. And very rightly, as Dr. Khan said, I just want to add to it. Human Care has a rich history of transferring patients. Almost 2,000 patients we have transferred till now successfully. So am I audible?
Yes. Yes.
Yes. Yes. Yeah. So the advancement in the healthcare, we all know, has touched several places, but only at the urban India, as well as even in the developed countries. Now, it is not possible for every unit or every hospital to get that kind of advancement. But it is a role of our healthcare practitioners to make people aware of the accessibility which human care works on. Accessibility of ICMO, accessibility of transplants, accessibility of home care, whatnot. So this, earlier it was a far-sighted dream, but now with the advent and with the increase in the, what we call the connectivity, we are transferring patients from A plus B throughout the world. It's very easy and it can be done just like a snap of your fingertips. So a lot of people get stuck and they say, okay, I could have done better for my father. I could have taken him there. I could have done this. I could have reached there. But now this reaching is not a problem. And this is the solution what human care provides. As a healthcare practitioners, we have the onus of providing These offers, these options to our patients that yes, there are options, there are better care, there are advancements which you can now access to with these kind of facilities. And that's the purpose which we are working on.
Yeah, thank you. Thank you. I think with the interest of time, with the interest of time, we would like to wind up. And this is a very interesting and one of the good session and eye opener for everybody. And
Hello.
yeah.
Hello.
Yeah. Anyone there?
Gunadhar sir, this is Akhilesh from Jaipur.
Yeah.
Please, yes, please.
Yeah.
Yes, Akhilesh.
Just wanted to thank for this session to everyone and all the teams who have given us this update. And I just wanted to acknowledge that the team who was speaking about transferring the BPCL patient from Jaipur to Chennai. I mean, I was looking after that patient. We have done a few prone cycles here, and I was really wanting to know the feedback that how is the patient after going there. And I just could acknowledge that that was the same patient they took from. I think they can confirm it. They took him from SDMH Jaipur, and I'm happy to know that he has done fine, because we have done prone cycles. We was also worried about his neurological status. So I just wanted to acknowledge that.
Thank
The
you.
patient
Thank you.
from our setup.
Thank you, Akhilesh, for your feedback. I think such kind of case reports are really going to help our budding intensivist, and so I really appreciate your feedback, Akhilesh. So with the interest of time, I think with no more questions, let's wind up the session. And I really thanks the speaker and all the panelists out here who have elaborately discussed regarding the aviation medicine and spend the time here with us in this Apollo Mumbai Critical Care Learning Network. And we do every such kind of sessions every Thursday, 7:30 to 8:30, and followed by discussion. So I like everybody to join in the further session. And we also going to conduct the mock exam for the upcoming DNV and IDCCM students on the January 21st and 22nd. So Dr. Swapnil is going to coordinate the thing. So Swapnil, you are there. So anybody who is interested to join that session, just contact Dr. Swapnil. And again, I would like to thanks all of you. So with this, I am closing the today's session. Thank you.